watered down the Neurosurgical Society, The World of Neurosurgery at Your Fingertips, es un honor presentar la siguiente ponencia del día al cargo del Dr. Walter Jean, quien es profesor de neurocirugía en George Washington University Hospital. Asimismo, les recordamos que la transmisión de esta ponencia se encuentra en YouTube, Facebook y Neurosurgical TV. And now, please, Dr. Natalia.
Yeah, thank you, Dr. Deya. My name is Natalia Fedorchenko, and I'm representing the organizing committee of the World Congress of Neuroscience, the World of Neurosurgery at Your Fingertips. We are welcoming all of you today. I would like to say many thanks to the chairman of the Congress, Ambassador of UNESCO, Mr. Jorge Herrera, for the idea of organizing the Congress and really great organization. Also, thank you for the cooperation with the Neurosurgical Society and Foundation for Brain Mapping, its president, Dr. Babak Kateb. Thank you to the WAPS Medical Students Chapter in Mexico and Neurosurgical TV for the broadcasting all our talks. And thank you to the Dr. Salim, our great moderator, neurosurgeon-in-chief of the Abdul Rauf Institute of Neurosurgery, founding chairman of the Department of Neurosurgery at St. Louis University, and global president of the Dandy Society. So Dr. Salim is going to present our moderator. Dr. Salim.
Thank you, Natalia. Thank you, Dea. I want to just commend the efforts of Jorge Herrera for really putting this amazing Congress together. We have a special speaker in front of us. Every generation of neurosurgeons in America develop leaders, and Dr. Walter Jean is a leader in skull-based surgery in the United States and respected around the world for his country. He's a professor of surgery at George Washington in Washington, D.C. Walter, it's great to have you with us.
It's a pleasure being with you. Thank you very much. I'm going to go ahead and share my screen and start my talk now. Wonderful. Thank you for everybody for inviting me for this grand occasion. It's a real pleasure to be so widely broadcasted and having such a big audience to be part of this talk, and honor is truly mine. Thank you, Dr. Abdurrahman, for that wonderful introduction. My talk today, the title is Extended Reality in Neurosurgery Towards the Goldilocks Principle. It is about technology. Every generation or so, the technology we use in neurosurgery jumps a couple of steps. And it used to be navigation technology, or it could be radiosurgery technology. And I really truly believe that virtual and augmented reality together, extended reality, is going to be the next quantum leap in advancement of neurosurgical technology. And we're going to be talking about that today in depth. What is the Goldilocks Principle? We're going to get to that in a little bit in the middle of the talk, but let's get started. One disclosure is that I'm a consultant for surgical theater who is involved in this technology development and propagation. So how did this all started? We're talking about, folks, virtual reality. What is virtual reality? It is a technology that allows us to turn two-dimensional ordinary MRI and CT scans into three-dimensional rotatable, manipulable, patient-specific three-dimensional models so that we can use them for patient engagement, consent obtainment, surgical planning, surgical rehearsal, and beyond. That is the technology we're calling virtual reality for now. It turns two dimensions into three dimensions, and all we need are really ordinary CT and MRI scans to do that. The very first step of use of this is in patient engagement. This is, after all, what the inventor of the technology intended this originally for. And you can see the use. This is a very celebrated case of mine at George Washington University, where one of our very first cases of using virtual reality to explain an AVM to a patient. Here's the inflow coming in green, the nidus of the AVM in ugly, angry red, and then the drainage in blue. You can see that we can open a craniotomy to explain the surgery to the patient, and even more important than that, explain the reason that she needed surgery in the beginning. What is an AVM and whatnot in three dimensions. And this is her specific anatomy used to do that. And often would give you the patients an aha moment, truly understanding why we need to perform surgery and how surgery would be performed. And of course, this is a headline grabber. This is very useful for patient engagement, and patients, of course, talk about it and very appreciative of the technology. And this is generates a lot of press for it, which is a very good thing. So it started off by being a patient engagement tool, making the patients understand more about the three-dimensionality of their pathology, and then it turns into surgical planning tool. The very first step of surgical planning is really just touring the anatomy in 3 dimensions. So again, 2-dimensional traditional scans, CTA, angiogram, can now be turned into a 3-dimension rotatable, manipulable, and alterable structure. Now you can look at the pterional craniotomy for that MCA aneurysm and see that your approach may be hindered because you are looking at the barrel of the aneurysm, and you may have a branch of it behind you that is hidden. So again, because this entire model is patient-specific and also rotatable, it shows you that the pitfall of this clipping is going to be that branch at the inferior temporal branch, which the craniotomy opening is going to hide from you, and the temporal lobe is going to hide from you, and there's the dome. So you go in there with a far better understanding that, you know, a instrumented assisted clip application is going to be necessary, and you have to be extremely careful about that inferior branch that you knew existed, because you had that 3D model that you rotated and rotated and rotated to study. So this is another step of the evolution of the utility of the technology. Continuing our surgical planning use of this tool, the touring of the anatomy continues. It happens that this is extremely good in distinguishing the onyx versus the live AVM. So here's a story where part of the AVM has been embolized with onyx, and in the CT scan, it's very difficult to tell where the onyx is and where the live AVM may be. Turns out, again, that this technology is very good at segmenting the onyx and the live AVM. So live AVM is now in green, and the onyx is on turquoise. And now you can, again, tour the anatomy to see where the inflow is to the live AVM. You need to pay a lot more attention to those inflow areas rather than the inflow to the onyx that is now very taken and not very exciting when it comes to surgery when you have to do the operation. So another step in the evolution of how we're using the technology, touring the AVM, understanding that the onyx is actually very easily visible in this segmentation process by changing that angiogram into 3-dimensional models. Once you start getting comfortable with manipulating these 3D models and turning them and rotating and whatnot, the next step is interacting with the anatomy. So not only are we just looking and touring now, we are now interacting with it, but maybe erasing some of it, drilling some of it, cutting some of it, and so on and so forth. Here's an example of that. Here is a patient who's going blind in the left eye, and here is this very unusual looking lesion that is perhaps on the optic nerve on the left side. Now, this, of course, becomes very useful to use 3D just to take a look at it. But now we're interacting with the anatomy. We're actually drilling the craniotomy. We're trying out a supraorbital keyhole. Let's just see how much of a small supraorbital keyhole can expose the tumor. All right, that's not bad. You can measure the angle of attack and say, okay, this angle of freedom is, let's say, about 45 degrees if I don't take the orbital bar, the orbital rim, and so on. Well, let's continue that experiment, if you will. This is just a model. You're doing this in the office. Let's take off the orbital rim. Let's see how much that increases our space and our surgical manipulability, especially if we take out some of the posterior orbital roof like you see here. So now we can remeasure that angle, the same instruments used as before, and now you could put it down towards the eyeball and say, wow, that actually doubled my my surgical freedom. And we chose, therefore, to use the second approach, which included the orbital rim removal. And there you have it. It actually was a cavernoma of the left optic nerve. And you see this in real life after the supraorbital keyhole which we did in addition, adding the supraorbital osteotomy because of how we interacted with the anatomy and measured our angles during surgical rehearsal. So that rehearsal gave us a lot of information that we actually utilized during the surgery. Let's take another example. This example was actually published in Operative Neurosurgery just very recently. This is an example of a pineal tumor. So here's a pineal tumor. Is which approach is best? Let's practice all the approaches. Let's rehearse all the approaches and try them out. This is an inter-hemispheric approach. And you can see that from a supratentorial approach, the corpus callosum is going to be shielding the tumor, which is also cradled by all the veins which are going to be in the way. Let's try a supracelebral infra-tentorial approach now. This is patient-specific models that we're using. This is actually that patient's anatomy that we turned into 3D. We can see that the precentral vein of the cerebellum is in our way. No big deal. That's to be expected. But look at my neck in this video. You can see that the tentorial angle may be a little bit prohibitive. What if we did a paramedian approach? From the left side underneath the tent, but towards the left side, not in the midline, you can see that the angle is much less steep and much more benign. And furthermore, the precentral vein of the cerebellum is out of our way. This turns out to be a very suitable approach. It gives us wide enough angles to do this. And this is how we end up choosing this approach. We chose it after surgical rehearsal, gave us the information that this perhaps was the best and optimal approach to this tumor. So you can imagine that if surgeons, experienced surgeons, are using this technology not only to tour the anatomy as well as to practice the approaches to surgical plan, we can use it for teaching. So the next step is using it for teaching, and everybody who's ever taught this extradural anterior clinoidectomy to a resident has been frustrated before by the complexity of anatomy or trying to explain this to the resident or the student in the anatomy lab. The biggest problem with teaching this in the anatomy lab is that the cadaver model in the anatomy lab is fixed on a Mayfield head holder that is not rotatable. And when we try to explain to them the unroofing of the optic canal and the removal of the optic strut, they often want to see the optic strut, and well, you can't turn that head right then and there. You're stuck in that operative position, and it's very difficult to explain those concepts to the resident in the anatomy lab. However, that's not the problem with these models. These models are infinitely manipulable, and you can use it to explain the anatomy here, for example, the superior orbital fissure, the optic foramen, the roof of the optic foramen being one of the anchors of the anterior clinoid process. You can explain all this by turning the model upside down, inside out, and then demonstrate the drilling of the extradural anterior clinoidectomy in not only the surgical position, but in multiple other positions to explain it. Here's the explanation of the optic strut, the drilling of the optic strut from the operative direction, and then re-examining the optic strut after it's been removed in all angles. Now the resident understands that, aha, that extradural clinoidectomy is done because it's all unhinged. And here example is an actual case that followed. The next example I have for teaching is this very complex concept of the one-piece, six-cut orbital zygomatic craniotomy. This is nearly impossible to explain well to a junior resident in one sitting, because the cuts are very complex, the anatomy is very complex. And again, once you get to the cadaver lab and you're trying to demonstrate this, the cadaver head is often fixed in one position, and you cannot explain all the anatomies as it goes on. Not so with these models. These models are very manipulable. As you can see here, the McCarty burr hole, we drill the burr hole, and we can show them that this burr hole gives them access to both the orbit as well as the anterior fossa, and this gives them an aha moment of what the McCarty burr hole is all about. And by the way, if the trainee practices that burr hole and puts it in the wrong place, you can simply just hit a reset button and the bone is pristine again, normal again, and they can start all over again to drill that burr hole. And then you can explain the cuts around the orbit in multiple angles that are impossible to get in cadavers. And again, the third cut and so on and so forth. And because of this manipulability, it is far easier to explain all these cuts to the trainee than in a either slide setting, two-dimensional setting, or in a cadaver setting. So again, it's an extremely good tool to explain complex cuts, craniotomies, approaches, and drilling processes for the trainee. And by the way, the detail of the bony anatomy is only limited by the detail of the scans. If the scan is 1 millimeter cuts and as thin as possible, and as imaging technology progresses, the anatomy is only going to be better in better displays. So down to the level of the cochlea and so on can be seen in these models to explain all these intricate anatomical structures to the trainee. So here you go, the 6-plut OZ craniotomy done, and there you have that example. Another example for you, I put 3 targets around the orbital apex to train our residents. So the blue one is at the top of the apex, the red and green ones on either side of the orbital apex. And this is a tiny little video to demonstrate the approaches to specifically target those points. So for example, this red target is specifically placed at the lateral aspect of the superior orbital fissure. And I'm trying to demonstrate here that an endo-orbital approach or transorbital approach gives you crazy easy access to this target. This is an intracranial view of the same target. And you see that the drilling from a transorbital approach really puts you right there at that target through a transorbital route. This is the green one, now medial at the superior orbital fissure, or orbital apex rather. And this one, I'm trying to make the point that if you do a sphenoidectomy, follow that optic nerve, drill that optic nerve, optic foramen underneath, and then follow it out laterally and distally, that green orbital apex target is to be had through a endoscopic endonasal approach. And now going for the blue target now, which is at the top, the superior aspect of the orbital apex, you can see that after all still requires the supraorbital keyhole, and the supraorbital keyhole puts you right at that target. And perhaps the other 2 targets are not as well exposed through the supraorbital approach. So again, makes the teacher's job a lot simpler because these models are so manipulable and makes the point so clear. I happen to like doing global neurosurgical missions, and very fortunately, my industry partner in the surgical theater has been very generous in supporting that, and we take this technology to, for example, Hanoi, to teach medical students and residents there, and we've done so the same thing, taking it to Panama when we went on the mission. And again, you can see the local residents in Panama using the 3-dimensional technology and virtual reality technology to learn our approaches and anatomies. Logic dictates if you can use it for surgical planning and teaching, then the next step is investigations. Why is this so good for investigations? It is intuitive. The reason why this is so good is because the anatomy is perfect, okay, down to millimeter precision. So the angles that you measure in the 3D models and the distances you measure in the 3D models are exactly as in real life. And there are unlimited specimens you can use. Lots of this research is done in cadavers. Cadavers are expensive and hard to come by. CT scans are easy to come by. There are plenty of scans that have normal bony anatomy that you can use for research. And so the substrate, the specimen you can use to power your studies is unlimited. You can do thousands if you really wanted to power your study for statistical analysis. Secondly, you're measuring the data in the same system, in the same platform as you are changing the anatomy. For example, if you're doing a craniotomy and you want to measure the opening angles, the measurement of the angles and distances are done in the same platform that you did the craniotomy in that showed you the anatomy in the first place. So you don't have to take the head to go to a scanner to register with navigation, to measure the angles, and so on and so forth. And finally, the reset button. The reset button is not only good for teaching residents who may or may not put the hole in the right places or make the right cuts. The reset button allows you to use one single subject's skull to do multiple approaches that may perhaps overlap. You cannot do this with cadavers because the cadaver bone cannot regrow. So if a particular specimen has a particular anatomy that with ridges and valleys and so on and so forth that makes it unique for collecting data, well, that collection of data, if you do two different approaches that overlap, can be done here, but not in cadavers. So that reset button makes it it's a very, very important tool that we can use to test out multiple approaches that may or may not overlap. Here is an example. Well, here are the anatomical studies that we have put out with virtual reality models, and we are only doing more and more as time goes by. Here's a brand new concept. It is using actually VR models, not of normal skulls now, but of patient tumors to do research of morphometric measurements. For example, here's a petroclival meningioma on a particular patient. We are testing the differences between the retrosigmoid opening and other openings. So here's a retrosigmoid opening of that tumor, and I'm trying to show you that the retrosigmoid opening produces some blind spots in this approach. Now, you see that as we go into the skull now, this is a completely unrealistic surgical view. Here are the blind spots. Those are the spots that are blinded to this approach as you do that microscopic approach, okay? The dark red and the bright red in zone 1 and zone 2 are the tumors. Now, let's compare the retro-labyrinthine approach for the same exact tumor. This is, again, the same exact tumor, but we did a retro-labyrinthine approach, and you can see that the residual or blinded tumor volume is actually much higher because, again, of the particular structure of this particular patient's skull. So now we are not using normal skulls to do morphometric measurements, but we're doing patient-specific measurements. And the reason to do this is very, very simply understood. Tumors can change the operative corridor of certain approaches. The tumor pushes things away. So if you do research in normal skulls that don't have tumors, you don't exactly know what the impact of the tumor is to your corridor. Here, you know the impact of the tumor to the corridor, and you can compare the different corridors because, again, of the reset button. You can reset the skull from the retrosigmoid to the retro-labyrinthine approach, and then you can measure the blinded tumors in each and compare and contrast. So, again, an incredibly important tool, and this is the first study of this kind that has ever been attempted, and hopefully it will reach the press very soon if the reviewers will allow. All right, so now remember that my title has the Goldilocks Principle. What, after all, is the Goldilocks Principle? And we're getting towards it. It has to do with the Keyhole Concept, the minimally invasive neurosurgery. The Keyhole Concept is becoming more and more prevalent in neurosurgery. Everybody's talking about it. We want to look through small openings to do big procedures, and we're always hoping that the opening, the view of the other side of the keyhole is as beautiful as that. However, there is always the chance that the keyhole leads us to an absolute nightmare, and what we see on the other side is not sufficient to do the job or to get the surgical goal accomplished. So how do we ensure that the keyhole shows us a beautiful view and not a horrendous view and make a mess? This is what I'm calling the Goldilocks Principle. Remember the Goldilocks and the three bears. Goldilocks went into the house of these three bears, and they found that one chair was too soft, one chair was too hard, and one bed was perfect, and the porridge was too hot, too cold, and one was just right. So this not too big, not too small, just right is the Goldilocks Principle of skull-based surgery. Why is that important? Well, it has to do with the three S's. We want it small because we want it not so invasive, but logic dictates that it could be too small, too restrictive, to be safe. So the size has to be not too big, not too big because we want it small, but also not too small to make the surgery dangerous, to make it impossible to complete the goal, the surgical goal. So that has to do with the specificity of where that small opening is located. it must not be too high, too low, too forward, too backwards. It must be in this anatomically specific spot so that a small opening can get the job done. All of this so that the surgical goal can be accomplished safely. So those are the three S's: size, specificity, and safety, that go towards the Goldilocks principle of keyhole minimally invasive surgery. So how does virtual and augmented reality help us achieve that? It is really by coupling surgical rehearsal with surgical navigation. Here's an example of that. Here's a juxtacondylar approach for a hemangioblastoma of the brainstem. Now, you want a small opening here because a big opening can disrupt the occipital condyle and disrupt the occipital atlantal stability. So, but you don't want it too small such that it becomes dangerous for the brainstem, that you would have to hurt the brainstem because the surgical opening is too small. So now we can practice the opening to make sure that it has sufficient room to take the tumor out, but small enough that it disrupts the occipital condyle as little as possible. So now here's the opening that we liked, that we practiced in the office, and we said this is perfect. It doesn't touch the occipital condyle at all. Now we're going to take this and save it as a computer file and take it to the operating room. We're now going to merge this file with the navigation system such that we can test out our real-time opening against this template, if you will, so that we duplicate the template in the operating room. So again, as we play the video continually, we are now in the operating room. The navigation is now locked into this template, and we are comparing our surgical opening in virtual reality with the template. A perhaps easier example to understand is this transtuberculum approach for this tuberculous cell meningioma. Again, you don't want this opening to too big, because then create a big CSF hole and whatnot. You don't want it too small such that it could be dangerous on the optic nerve, not enough exposure. So you practice the opening in the office, and you save a template for the ideal opening, and then you merge that opening with the navigation system, and you continuously compare the navigation during the operation with the template that you created, and generate the best opening you can, the Goldilocks opening that you practice in the office during the surgery. So again, this is the concept of that optimizing skull-based approach using Navigate integrated virtual reality templates, the templates generated in surgical rehearsal. We're going to go the next step now. What if we now change virtual reality into augmented reality, and we actually put the template and inject it into what provides vision for us in the operating room? And that, of course, I mean by integrating the augmented reality objects into the microscope display. Now you're really saying, okay, you're going to generate the template, save it as a file, as an augmented reality file, and then you project it through a navigation tracked microscope, and you can see the template overlaying on the patient's real-time anatomy, anesthetized anatomy, and in the operating room to now duplicate the template. Now this is really getting advanced usage of this. Now no longer are you turning the MRIs and CT scans and 3D models just like that. You're also then saving this file and projecting tumors, markers, burr holes, openings through the navigation tracked microscope in the operating room onto the patient in real life. So now we're using augmented reality for navigation. Okay, Goldilocks principle, AR plus navigation. Here's a very straightforward example, and it also demonstrates the concept of the operating inside out. Okay, here's just a very straightforward example of a metastasis that we want to take out. Now, how do we use augmented reality to minimize that opening? Well, let's take a look at the 3D model first. In virtual reality, there's a tumor. All right, we're going to take that brain away. We're just going to look at the skull, and we're going to go inside the skull. Now, we're going to make our burr holes from inside out. Why? Because that gives us the best information of where those burr holes need to be to make the opening as small as possible. Here's the burr hole number 1, put the burr hole number 2, put the burr hole number 3. We're drilling inside out so that we know this opening is perfectly sized, as small as possible to take out this tumor. And we're going to put markers so that we can project those intraoperatively to show us where we need to be. We're going to, again, continue the drilling of the craniotomy inside out. And again, this ensures that the opening is as small as possible. The wing may be, okay, so here's that template. We're going to go back out, take a look at it, and we're going to make the bone disappear here. And boom, that is our template that we're going to take to the operating room and project it onto the patient. Okay, now, real life. There's your patient anesthetized. There's your model that you saved as a template projected on the patient. We're aligning the virtual probe with the real probe in life, so to make sure the navigation is all set. You can use your fingers to look at landmarks and make sure that the AR and the patient anatomy is congruent. Now, you see those burr holes. You're going to mark those burr holes on to the patient's skin and the opening onto the skin. And that marker actually allows you then to plan the incision. There you go. That's where we need to be. That's our incision. So the incision is planned inside out as well. So there you go, the markers again, with the bone exposed now in surgery. And that template is simply duplicated in our drilling. We drill through that augmented reality overlay and we duplicate our opening, and there's your opening. So you know that this is going to be sufficient to take the tumor. You know that this is as small as you can make it to take out the tumor. This is just a very simple example of how you use these templates for the Goldilocks opening. Now comes a more sophisticated example of a burr hole microvascular decompression. The microvascular decompression can be done through a very, very tiny hole if that hole is perfectly placed. That has to be right at the transverse sigmoid junction. In real life, we don't have that luxury. It's very difficult to find that position in two-dimensional navigation. Here, we're drilling inside out again. We'll drill that hole inside out at the transverse sigmoid junction, and we're taking that template to the operating room. You see that blue marker down there at the bottom? We're going to mark that, and that's where the hole needs to be. That's the hole that we did. And it's completely matched between the template and the real life anatomy of the patient. That marking then dictates where you put the incision. That marking then, again, is brought in, that template is brought in with the bone exposed. And now you're going to remark that template onto the patient's actual bone. And you simply duplicate that opening that you did in the office. You know that that's going to be right at the transverse sigmoid junction, and you know that that's going to have enough room for you to put in that sponge because you've done that in the office. You know it's perfectly positioned. So we completed that microvascular decompression without any problems, and you can see it's a 13mm burr hole with the microvascular decompression completed. So that is another example of the Goldilocks opening, more of precision of location than of size in particular. All right, here's an example of a Klein-Neumann meningioma. How can that template help us with this? This was recently published as well. And what this does is that it places that mini-pterional opening perfectly where you need it to be. So this is a patient that was losing sight with a growing meningioma of the clinoid. It's a LMFT group 2. And it is actually very accessible with multiple approaches. So let's test out the approaches in surgical rehearsal again. Let's test out first the supraorbital approach. With this time, we're going to go ahead and take the orbital rim as well without hesitation. We're going to drill down to the anterior clinoid. We do the anterior clinoidectomy, just like we always do. And then we say, voila, that's plenty of room to take out the tumor through that opening. Why not try the mini-pterional? Here again, I want to stop this right there. We are drilling that mini-pterional from inside out. Again, because you want that mini-pterional opening, that 3-centimeter opening, to be perfectly placed. That gives you access to that sphenoid wing without having to fuss whether it's too high, too low. And then if you're unsure it's too high, too low, it becomes bigger. So being very specific with location, you can make that pterional opening quite small. So we put that burr hole at the tip of the lesser wing, and we're going to put a marker there so we can see that intra-op. Now we know that we can just drill an opening that's slightly superior, but mostly inferior to that opening. And that gives us access to the drilling of the sphenoid wing perfectly. And it gives us an access to the anterior inclinodectomy perfectly, et cetera, et cetera, et cetera. So the two approaches that we practice here gave us equivalent exposure. We decided on the mini Teriono because the mini Teriono, well, she didn't have an eyebrow to hide the incision for the supraorbital. So I thought that this was better done this way. And we move on to the next phase, which is now taking that template and taking it into the operating room. Patient anesthetized and positioned here. You can see the eyebrow. You can see the tumor projected onto the patient's skin. And there's your opening projected onto the patient's scalp. You know exactly where that Teriono opening needs to be. You mark the Teriono opening as you had practiced in the operating room onto the patient's scalp. That helps you plan the incision as well, not to hurt the frontalis. Mobilize the soft tissue. You reproject that opening onto the patient's bone now exposed, and you remark that burr hole with that marker, and you drill. And again, you just simply duplicate the opening that you had practiced in the office, and voila, it takes you there. I'm not going to belabor the point because we're slightly running out of time. We're going to move forward to the next example, and then so on. So small incision, tumor out, no problems. Now, another use mainly for safety. Middle fossa floor, drilling. Deep structures are a problem sometimes. Labyrinth, cochlea, the 7th and 8th cranial nerve that are all hidden by the floor of the middle fossa can make the drilling of the anterior petrosectomy somewhat challenging because you don't want to hurt those things. And believe you me, I have hurt the cochlea doing this by billing too lateral. With augmented reality, not only can you practice this, you can also have X-ray vision, if you will. So here's the tentorial meningioma that we want to do through an anterior petrosectomy. We're going to practice that anterior petrosectomy in the office. The green marker is going to show you the lateral aspect of Meckel's cave, which is as far anterior as we need to be for the drilling. Here's foramen ovale, so we're going to put that marker right here. And as we practice this anterior petrosectomy, we can change the density of the bone back and forth so that we can see those structures that we have segmented, the cochlea, the labyrinth, and so on and so forth, so that we're basically drilling with X-ray vision. Now, you're not just practicing with drilling with X-ray vision. This is the completion of the surgical rehearsal. You now are going to bring that template into the operating room and drill an actual real life with X-ray vision. So here it is. Here's the floor of the middle fossa, and the markers are just as you had rehearsed. The green marker is the anterior extent of the petrosectomy. All the other structures are there for you to see. And because the microscope is being tracked by navigation, those are anatomically precise. These are exactly where the cochlea is. In this patient in real life. So just by avoiding that blue area, you know you're going to avoid the cochlea. Just by avoiding that purple line up top, you're going to avoid the internal carotid. And you're never going to be able to drill into those things, even if you wanted to, because you can actually see them with X-ray vision. Again, tumor comes out, everybody goes home happy. The final example I'm going to show you is the middle fossa approach for acoustic schwannoma. Not to belabor the point, this is this surgery is indicated for small tumors that are lateral in the canal, and it is often very challenging, even for seasoned otologists, to find the canal sometimes with all the angles and having to measure the angle of the GSPN and the arcuate eminence and so on and so on and so on and so forth. So, of course, navigation has been used. But the difficulty with navigation is twofold. One is that you're trying to find a three-dimensional object, which is where the tumor is, in a two-dimensional navigational setting. And more importantly, two-dimensional navigation is almost always wand and monitor based. So you have to look away from the operative field to find out where you are and then look back. That is not exactly the most conducive to safe operating. So how AR changes this whole game is that by projecting the tumor into your field, you actually have X-ray vision towards the target. You can see exactly where you need to go, not having to turn the head, not having to look at a monitor, and finding out exactly where you need to go with X-ray vision. So again, practicing the craniotomy And we're going to practice the drilling of the middle fossa floor with all the structures segmented, and again, fading the bone in and out so that we know where we're going. And we're just going to simply drill right towards the target. There's no ifs, ands, or buts, no measuring of angles, no need for finding the arcuate eminence, and so on. And there you have it right there. So now what you do then is you take that template into the operating room and you can drill towards the target in real life, having seen it. Now, I only have the experiment to show you. What we did here is we used a 3D printed skull. This is a 3D printed skull of a patient with a tiny schwannoma lateral in the canal. And you can see that the 3D printed model aligns with the augmented reality very well by looking at the superior cerebellar artery and the brainstem. And what we're going to demonstrate is that we're going to drill right towards that green target there, not having measured any of the angles, not even having the GSPN visible, and so on. And you will see, I'm not going to show you if we failed, obviously. You're going to see that we succeeded in drilling right towards the tumor, which is painted green in this experiment. Let's advance the model a little bit, and there you have it. So just by following the cue of the augmented reality template, we arrive at the tumor with absolutely no problems at all. So there you have it. That is the shape of things right now, and we are very excited for the shape of things to come. So conclusions: virtual reality lets us do rehearsals and create templates with the Goldilocks opening. The templates are navigable in both VR and in AR. And with those templates, you have the perfect size, the perfect anatomical specificity and location, and it even gives you X-ray vision to avoid pitfalls and no-fly zones, such as in the middle fossa floor. And all of that provides you with cues and whatnot to generate the perfect minimally invasive keyhole opening to safely conclude and accomplish your surgical goal. And by the way, this operating inside out concept is very, very useful, because even for bigger tumors that you cannot maybe do a keyhole, it allows you to do as small opening as possible. So for anybody who's in the field of using virtual and augmented reality, I encourage you to submit for this focus issue that's coming up in August. I am the lead topic editor for this neurosurgical focus issue, and I think that this issue is going to be tremendous in documenting what the current shape and perhaps the future of augmented and virtual reality is in neurosurgery. And here I am. I'm not hard to find. And I hope that everybody has enjoyed my book, who has a copy of that. And again, it is my great honor to be here today, and I would love to hear some questions.
Thank you, Walter. That was a very cool talk, really cool talk. It really talks about a lot of the evolving concepts, and ultimately to improve outcomes of especially the more complex operations. There are a couple of questions, Walter. One question is, I'm just going to paraphrase it. Essentially, have you used VR for a brainstem cavernoma, something that comes close to the fourth ventricular surface area? Have you had any opportunity to use the technology for something like that, a CM of the brainstem?
I have not yet. That is a clear indication for this. You can paint that cavernoma in augmented reality and project it. You can see through the brainstem then to see where your target is. And you can, furthermore, you can actually bring in your DTIs, you can bring in your tractography and see that, oh, perhaps I should come over a little bit over here, perhaps a little over there, to avoid the essential tracks. So that is absolutely key, a great indication for the use of this. And I'm looking forward to the next chance I get to use that.
That's great, Walter. One more question. One of our neurosurgeon colleagues is asking, how do you think about VR compared to or in relation to intraoperative MRI for resecting?
Night and day. I've had I used the intraoperative MRI early on in my training in Minnesota when it was still very young. There is definitely indications and utility for intraoperative MRI, but there you are taking the patient out of the operation, scanning him in another room, bringing them back to do more or maybe less. You can't do less, maybe do more, seeing where you're seeing. It's no question that it's actually apples and oranges is really what it is. That is really very useful for gliomas, low-grade gliomas in particular, because you can't see it. And once the brain shift happens, then your whole navigation's off. And you need the intraoperative MRI to give you more indications where to go. I can tell you that with AR and VR, as soon as brain shift happens, you're done. It's just as useless as traditional navigation. So intraoperative MRI, critical for those kind of things. AR, VR not good. But AR and VR is really good for skull-based stuff, because there you're not talking about brain shift. Brain shift is not a thing for a clinoid meningioma or anything like that. So they are complementary things, not mutually exclusive.
Thank you. Thank you very much. And just as we're speaking to a lot of students around the world who are interested in neurosurgery, question I get asked a lot, Walter, what do you recommend for students who want to go into neurosurgery? From where you sit, you've had a lot of experience. What is your general pearls to tell students who want to go into neurosurgery?
Be as thirsty as possible. Be as, if you're passionate about it, seek out all the lessons that you can learn, seek out all the venues that you can gather knowledge, and be as thirsty as possible and drink it up. Drink it up, because we are at a juncture in neurosurgery where things are exploding all over, right? And we're talking in very general terms, not just skull base or tumor or anything like that. There's advancements in vascular neurosurgery. There's now interface between endovascular and functional neurosurgery by brain machine interface. There's obviously advancements in DBS technology, and tumor research is also heading in the right direction as well. So this is a great time to be a neurosurgical trainee, and be thirsty, be passionate, and learn from every angle you can.
That is great stuff, Walter. Thank you so much. It was really a cool, beautiful presentation you gave us about some of the cutting edge stuff that's coming. And thank you for your time. And we look forward to you being with us in future such initiatives that we're planning for 2021.
Thank you very much. It's a great pleasure and it's a great honor being with you today.
Great. Thank you. Thank you, Dayanara. We will now go offline. Great. Thank you so much.
Yes,
okay.
Thank you, Doctor.
Yeah, good to see you. So no more today. And then tomorrow, I will tell Natalia that's very early in the morning, 6 in the morning for me. So she'll present Dr. Mustafa